rate testing contractor or through our medical review department, you have appeal rights. And so what you want to do is you want to submit that documentation and you want to identify for us specifically why you believe that the procedure code should be something other than what we have chosen. We had a question that came in that said, should the doctor actually be identifying how severe the patient's case is, the encounter, either through the problems or through the risk? And the answer to that is yes. The best practice is to identify exactly what is going on with that patient. The determining factors for deciding on the level of service is going to be the information contained in that document. So let's take a look then at some of the documentation examples that we have for you. So in this first example, we have the history. So the patient is coming in with a wrist injury. We have information there on the fact that the patient had a mechanical slip and fall on the ice on Friday, injuring his right wrist. He thinks he landed on it. It identifies for us where the pain is at for the wrist and the hand. It also indicates that he did not strike his head and has no other trauma. Patient is denying any neck or back pain. He has been using conservative treatment at home. We've identified some allergies, and there's no facility administration medications on file prior to this encounter. So obviously he is experiencing pain. That's why he has come into the ER. He has tried the conservative therapy. The fall did not happen on the date of service. It tells us here that it happened on Friday. I think from the actual date of service, that would have been maybe 2 or 3 days prior to the actual ER encounter. The practitioner did ask about other injuries from the fall, and the patient, as we see, he did not strike his head, has no other trauma, denies neck or back pain. Basically, the patient is in there because his wrist is hurting. So then we have both a medically necessary history and exam that's listed here, both on this slide and the previous slide. You can see here that the exam did include the head, and with that, the exam of the head shows that it was atraumatic. There's no identified information about the head. And then it does, of course, mention that pain in the wrist. The next thing that we have is data. So we have no labs that have been done. It does identify that we have a wrist x-ray that has been done, and it gives us the response of that. No acute fracture or dislocation. So you also want to point out to you, it says the laboratory results, imaging results, and other diagnostic exam results were reviewed in the EMR. Now that terminology reviewed is important because it's not indicating that the physician or the practitioner did an independent interpretation. What they're telling us here is that they simply reviewed this data. So then we go on to the medical decision making. The patient does not have a fracture based on the review of that x-ray. The patient is being advised to continue the conservative treatment that they've been doing at home, and the doctor is recommending ibuprofen rather than the Tylenol. Ibuprofen is an over-the-counter medication. There's no mention in this note about other medications or other issues that may affect the taking of that ibuprofen. So let's talk then about our findings for this one. We have a straightforward problem, which is one self-limited or minor problem. The problem is transient in nature. It usually runs a definitive and predictable course. The problem is not likely to permanently alter the patient's health status, and we don't have any head trauma or other issues from the fall. The data is also straightforward as we only have one test ordered and reviewed. And of course, the review of the test is part of that order. You would not count those separately. So this would not qualify for low as it does not meet category 1. Category 1 does require 2 of the items listed in that AMA document, and that could be review of prior notes from an external source, review of unique tests, or ordering of tests. And you have, for the test part of that, you have to have at least 2 of those. Risk is also straightforward. The risk injury and the treatment order pose no risk to the patient. We have nothing within that provider's documentation that indicates the taking of the ibuprofen or the conservative treatment, anything like that, pose a risk to that patient. Now, as you can see on that documentation, we would probably not think of this as an emergency situation. However, the patient did present for care into the emergency room. Therefore, this is an emergency room visit, and you can submit the emergency room procedure codes. Now let's take a look at this next one. This is a situation where Medicare actually received 2 ER visits for the same day. Medicare is only going to pay for one of those unless it meets an exception. And the exception to that is the services are unrelated and could not have happened at the same time. During the first visit, the patient complained of pain in the thighs. So this particular service was actually denied. You can see the chief complaint of homelessness here. The history gives the example or the scenario of how the patient actually came to the emergency room. They were sleeping outside, and an ambulance picked him up and transported him to the emergency department. You can see in the past medical history, the patient does have cerebral palsy also. So let's look at the exam then. They did take vitals for the patient, and all of those are within normal limits. They did a physical exam. They're indicating he's in no acute distress. He doesn't have anything that's going on for this particular encounter. Then we go into the exam, some more information. We do have a general deformity under the musculoskeletal, where the left lower extremity is internally rotated, and I'm sure that's from the cerebral palsy. When you look at the exam part here, there's nothing else that's listed. There's no findings for an exam, etc. Under the data, as you look through this, we have no data that has been ordered. We have no data that has been reviewed for this particular patient for this encounter. Then we have the information on risk. And as you can see here, we can really see what happened here. Patient was examined, they were evaluated due to homelessness. Vitals were taken, patient was alert and oriented, all of that type of information. Patient was provided sandwiches and juice. Patient was informed they could sit in the waiting room until their ride arrived. Patient was also instructed on return precautions should he fall ill after being discharged. Now, as you can see on there, some of that language probably is standardized language because they really, there's nothing going on with that particular patient. So if we look at the next one, then we've just got some additional information. Patient planned to discharge home. But look at some of the information on here. We have shared decision making. What type of decision making was shared? The patient was given sandwiches and juice and told they could wait in the actual waiting room there. They discussed escalating patient's care. Escalating it to what? This particular language here, patient will follow up with the PCP. Results were discussed at length. What results were discussed at length with the patient? Patient agrees to the plan. What was the plan? So we can see here that this language really is kind of some standardized language that we have in here, and it really does not match what actually happened with that particular patient. There's a couple of places in here where it says, as per my usual custom. Um, in this situation, it's really not appropriate for exactly what has happened with here. When evaluating documentation, you want your physicians and practitioners to verify that their language matches what actually happened. Using and having some standardized language that your doctor can pull from, there's nothing inherently wrong with that, as long as it actually goes with whatever happened to that particular patient during the encounter. Now, our findings on this one is that Medicare would not make payment for this. There is no medical necessity for the service. Yes, the patient did present to the emergency room or was actually taken to the emergency room, but there's no treatment of any illness or injury. There's no treatment or diagnosis to affect a malformed body member, etc. So in this situation, while Medicare did pay the original evaluation and management service that was submitted for this patient, because of the pain in the thighs, he had a problem that they were addressing. The second one would not be payable based on the medical necessity. Now let's take a look at the third example. Now in this one, our chief complaint is a fall. So we have history that's given here. Patient is 76-year-old male brought to the ED for evaluation following a fall at home. History was provided by an independent historian. Now, it doesn't indicate necessarily who, it just indicates that it was a patient's relative. So, what we want to think about, do we need this independent historian? Because if we don't need this, then the fact that the patient's relative provided the information does not go into coding. But let's continue on in our history example. The relative reports that the patient was in the garage and fell, but the fall was unwitnessed. So we don't have information here, and the practitioner would not have information about how long that patient was there in the garage before someone actually came and found them. Following the fall, the patient appeared to be confused and could not remember how he fell. The relative is reporting that this confusion lasted for about 30 minutes. Now, we want to keep in mind, this is after the patient had fallen and relative to the time as to when that relative actually found them. However, they do state that they appear to be at neurological baseline. The patient is reporting a laceration to their left elbow following the fall, but they deny any other pain, such as neck pain, back, or abdominal. Patient is denying chest pain or shortness of breath. Patient is anticoagulated with Eliquis, as we can see here. Patient denies any medication changes as well as alcohol use. He informs that it has been over 10 years since his last tetanus update. There's no further complaints at this time. So now let's look at the exam. So when we're talking about the head, they've reviewed the vitals, obviously taken by the nursing staff. There's information there in the comment that there's no evidence of trauma to the face or to the scalp. Patient, again, remember from the previous slide, is not having any pain or anything to the head. They go on in the neck area, and there's no tenderness there. There's no deformities. There's nothing that's being identified there. When we continue on with the exam, we do find that the wound is present. We have a 3 centimeter laceration over the left elbow with subcutaneous tissue extruding from the laceration. There's no active bleeding going on at this time. We also have information here that the patient is awake, alert, and oriented to person, place, and time. Their speech is clear. They can move all of their extremities. Strength and sensation are intact on all of their extremities. Pulses are normal. Pupils are equal and reactive. So there's nothing else there that we have other than the laceration. So we also have some additional information here. Patient was seen and examined. Now on this one, they're identifying it as a 2 centimeter laceration. And again, they're identifying the location. They're identifying that a laceration repair was performed, and we have a procedural note on that I'll show in just a second. We do have multiple imaging studies and multiple labs. An IV was established, but it's not giving us any information about any medication that may have been used there. It looks like they have just established an IV in case they need it. And they updated his tetanus shot. So now let's look at our data. So we have data for the x-ray of the left elbow. It identifies that there's no fracture or foreign bodies involved in there. Official radiology read shows no acute fracture or malalignment. So we want to pay attention to that language, independently interpreted. So that's part of the data that we can count. And then it goes on to give some additional information there. We also have a CT of the spine. And the CT of the spine shows no acute fracture. We have a CT of the head without contrast, and it shows that there are no problems with that. It also identifies while suturing the patient's heart rate was fluctuating. They did experience some bradycardia, asymptomatic. They discussed a monitor placement, which the patient was agreeable to. They did do an EKG. So all of this information then would go into the data. One of the questions that we have received talks about how to count the risk of a CT or a CT with contrast. Well, it all goes back to the proof of thought of that particular physician or practitioner. What is the risk to that patient from simply doing a CT or a CT with contrast? If the documentation, and this documentation does not, it doesn't indicate that there's any risk to that patient from doing those particular testing, doing those CT scans. So the order of a CT scan or a CT scan with contrast in and of itself does not increase the risk to that patient. So now let's look at our procedural repair. Here we have the operative report. Based on this, the documentation, or based on this documentation rather, the code would probably be a 12002. This has global days attached, although it is 0. The code is chosen based on the 3 centimeters listed here to close the laceration. Um, One of the previous slides did show this was 2 centimeters, but they are identifying in the procedure note that it was 3, so therefore we can use the 12002 code. Now, based on the information that we have, we would allow the surgery procedure code along with the E&M. The documentation does show that this is a significant and separately identifiable service from the actual procedure itself. So we would submit this using the modifier 25. Now, the surgical code would not be submitted with a modifier because it is a minor procedure, either the 0 or 10 days, in this case 0. The ER physician would not have to use a modifier. If the procedure, if that laceration repair was a 90-day post-op, then they would need to use the 54 modifier. Okay, now look at this one here for a second. When I'm looking at this, I found the list of diagnoses a little concerning. Here we have listed a closed head injury. Well, based on the history from the patient and their relative, based on the exam, where does it show in that documentation that there was a head injury? Now, we did a CT scan, and again, we want to think about that one. Patient is stating they did not hit their head, or they don't think they hit their head. The doctor's exam does not indicate that they hit their head. Doctor's exam also does not indicate that there, is something going on, maybe a concussion, maybe an internal bleed, something along those lines. So that's a little concerning with ordering the or identifying a closed head injury as an actual diagnosis for this patient. We also have, of course, the elbow laceration, which is listed there, and then we have a fall from the stairs. Where the closed head injury could become problematic for this patient is if the patient becomes confused again. Maybe tomorrow they're again experiencing confusion. Someone else may look at this and think, oh, this is the result of the fall. We already have a CT scan of the head, and so therefore, maybe we don't need to do anything else. However, confusion, if the patient comes back in with confusion, that could lead to other diagnoses, other things that emergency room physician or their primary care practitioner may want to do for that patient. So that's just something to kind of think about. So on this one, our findings were the problem was moderate. I believe this would fall into one acute complicated injury. We have the fall, we have the confusion, and then we have the laceration to the elbow. We also have an indication of the bradycardia during the suture removal. We really don't have a severe exacerbation of a chronic illness, and we don't have a situation that poses a threat to life or bodily function. We have that mention of the bradycardia, but the physician is not treating this. The note does not indicate that he or she actually ordered the monitoring or any treatment for this. For the data, we had this one as high. We do have an independent historian. And based on the documentation, the fact that the patient was confused for approximately 30 minutes after the relative found them really means that the practitioner needed that additional information from that independent historian. An independent historian, and you want to think about this one, it is needed for the patient. So that means that the practitioner cannot really rely on the information given to them by the patient. With the fact that this patient had that confusion, we can fall into that category. The relative states that the patient is back to baseline, but we don't necessarily know what that is. We also have the order of the elbow x-ray, the CT scan, and then the EKG. This is 3 tests along with an independent interpretation, and we have no information that the provider billed separately for these interpretations. We chose moderate risk based on the bradycardia. The ER physician mentions this and suggests using a monitor. The documentation does not indicate whether the surgery is major or minor for that patient. And that's really what you want to look at in your documentation when you're talking about risk. What is the risk from the disease, the illness, the injury, and what the physician or practitioner is determining to do for that patient? Now, in another patient's case, you have a patient maybe who had uncontrolled diabetes as part of this ER visit. The laceration repair, maybe that could be more risky for them. You have patients who have difficulty breathing or heart trouble or something else. That minor laceration repair could become more risky for that individual patient, but your documentation will have to show that. One of our contractor medical directors really calls that proof of thought. Proof of your documentation is proof of what that physician is thinking for that particular patient. When you're dealing with surgical procedures, Medicare has minor surgeries, we have major surgeries. That all has to do, though, with the global days. You could have a minor procedure that poses a great risk to your patient. Document that. You could also have a 90-day global procedure that really doesn't pose a high risk to your patient. You need to document what needs to be documented in the record is that risk to that specific patient for exactly what the medical decision making is. So now let's look at example number 4. This example is also one that Medicare denied based on the fact that there were 2 on the same day. So you can see here that the patient was seen for a nosebleed. They have been seen earlier within the past few days for the same thing. We can see here that the physician has identified the severity of that nosebleed as moderate. It's lasted for about 6 days. We also have, however, our progression shows that this is resolved. This does show that the patient is on warfarin. So let's look at our physical exam for this one. We have vitals and nursing note reviewed. We have an exam that has been performed. We have identified that the patient has a rhinorucket in the left nostril, does have dried blood around it. No active bleeding though. They also looked at the right nostril and there's no active bleeding there too, or either rather. Then we have information on data and risk. We don't have any labs, we don't have any imaging. Under the medical decision making, it does indicate patient is fairly anxious about the balloon. They did offer observation stay for this patient, so we want to keep that in mind. Patient, however, at this time does not want that as they don't have any further bleeding. The patient understands that this bleeding may come and go over the next few days, they need to be watching that. The mention of observation again goes back to that proof of thought by that physician. So let's talk about what our findings are here. We have a moderate problem. This would fall into one acute complicated injury. The patient has been bleeding off and on for 6 days. Patient does have packing in place and they believe that the packing is not working. Under data, we would have straightforward, as we don't have any data that the physician has reviewed. And under the risk, we would have high. The ER physician thought about and offered the patient observation care. The ER physician also explained that the nosebleed would wax and wane until it was actually resolved. Now, here is the second visit. Again, these two visits are on the same day. Medicare doesn't pay unless it's unrelated, and it could not have happened at the same time. Well, as you can see here for this second ER visit, the diagnosis is the same. Again, the person has the nosebleed and they've come back in for that. So the services are related, therefore Medicare would only pay for one. So if you have this situation, what you're going to do is put your notes together for both of those services and then choose based on the medical decision making, then you can choose the procedure code that best supports both of those services. So here's our notes on the history. It continues, or it mentions the continuing episode of the nosebleed. The patient is taking his Coumadin. The INR has been reviewed and it is too high. Patient was previously told to hold his dose, not to continue taking that until the nosebleed actually stops. So now we have some comments and then we have labs that have been taken for this one. So for this visit, we have the testing, the red blood cell count, hemoglobin hematocrit, the INR test as listed there, etc. We don't have any specific indication of an order, although we obviously have lab results that were reviewed. We also notice that the INR on this page is a 3.1 rather than a 4 as it was previously stated. We could make an assumption that this is a new test for this particular patient. So again, we have no imaging that was done for this patient. Documentation does show that his INR is trending down. They have given them instructions about continuing to hold the Coumadin until the bleeding stops. The ER physician again is suggesting observation care and a possible consult by an ENT. This also lists the nosebleed and identifies it now as an acute illness or injury. So now we have information about what happened with this patient. This patient was admitted to observation by that ER physician. Up at the kind of in the middle of your page on the right-hand side, it shows the ordering physician. That ordering physician is the same physician who actually performed the ER service. So they're going to now place this patient into observation care to watch this nosebleed to make sure that they actually can get it stopped. So for this second visit, again, Medicare does not pay for two, but the problem again would be moderate. We fall into the one acute complicated injury or illness. Patient has been bleeding for 6 days. They have packing in place and they believe that that packing is not working. They do have multiple lab tests that they ordered and reviewed for this one. Again, the risk, the physician thought about and offered the patient observation care. The ER physician also, told them that the nosebleed would kind of go and come until it was resolved. In this situation, the patient did accept the observation care. And then this physician really did actually admit them to observation. So you can see our problem is moderate, our data is moderate, our risk is high, and then we have the procedure code listed for you there, the 99284. Now, as I stated, Medicare does not pay for two E&M services on the same day unless those exceptions apply. So Medicare would not have paid for both of these visits. You would have needed to gather up the documentation and then choose a procedure code based on that documentation. However, what we want to look at here is that this MD actually ordered that observation care for that patient. So based on the documentation, the hospital then would see that ER physician as that ordering physician, and then the ER physician is the one who's going to be responsible for that patient while they're in observation care. So really the correct coding for this service should have been an initial inpatient procedure code along with the AI modifier. Now, again, then that would mean that the ER visit then would not be a payable service, that first ER visit. Again, you can use documentation from that as long as the two services are by the same practitioner or the same specialty in the same group in order to choose your procedure code. So when we looked at this documentation, we chose the 99222. We still believe that this service is moderate based on the documentation. But again, it really should have been billed as the 99222, the initial inpatient procedure code, as opposed to an emergency room procedure code. So next we're going to take some questions. I have just a few that came in with the registration. So one of the questions was, the patient has had a fall, kind of like the example that we had before. The provider is checking for head trauma. Could it be a complex situation or complex problem, even if the final diagnosis is contusion? And the answer to that is yes. You don't have to have a definitive diagnosis when you're starting out this encounter with your patient. So what we would be looking for within the documentation is the evidence of why the physician believes that there is head trauma. In that first example that we had, first or second example, I forget, the patient had fallen off of a ladder. There's no indication in there, in that documentation, that there could be a problem going on with that patient's head. That's why we kind of questioned why there was a CT scan of the head done. However, if your documentation is showing that there could be a problem with that, patient is still confused, they do have a lump on their head, whatever the situation might be, then your problems could be considered as more complex than simply the contusion itself. So with a high complexity problem, it's an acute illness that poses a threat to life or bodily function. So show the proof of thought. That's what needs to be in the documentation. Why does that physician or practitioner believe that this is a high problem for that patient? Another question that came in talked about a decision for a hospital admission, even though the patient was not admitted, or that physician cannot admit the patient. And the answer to that is yes, you can count that. That again goes back to that proof of thought. The ER physician believed that that patient should be admitted to the hospital. If they are transferring that patient's care to a hospitalist to actually do the admitting, then the ER physician, yes, can still count that. Another question that we had was, the patient was on a 48-hour psych hold. And so for that second day, how would that be billed? Well, you really need to look at what situation you have. Generally speaking, patients are not going to be in the emergency department and listed as emergency department patients longer than 24 hours. At some point during that actual encounter, more than likely that patient has been moved into an observation stay. However, if the patient really is still an ER patient, that second day is going to be billed as an office or other outpatient procedure code, not another ER visit. If there is repeat testing, this was another question, the documentation needs to show why that testing was repeated. And then another question came in concerning the minor or major procedures and how you determine that. And that is based on that physician or practitioner's documentation as to what that risk is for that patient from whatever procedure it is that they're either doing or they're recommending. This isn't like normal risk. All surgical procedures have risk, obviously, but this is the specific risk to that patient from the problems that they have and the medical decision making that your physician or practitioner is doing. So we'll go ahead and open it up for questions. Rachel's going to read those off for us.
All right. So our first question, if the patient's in the ED and they go into observation, is the ED charge invalid if the provider ordered the observation? Can you charge the ED and get a denial, or do you not even charge the ED and only charge for the admission to for observation?
That last statement is the one that is correct. If you're going to bill for that observation care, because you're the one who is ordering that, that's considered the higher level service. And so you bill that one, you would not bill the ED visit. Next question.
All right. In example 4, where the MD ordered observation and it should have been initial inpatient, what if your ED physicians do not have admitting privileges?
Okay, and that's one of the questions that we talked about. If your ED physician does not have admitting privileges, and so they're not actually admitting that patient, but the hospitalist is, or someone associated with that hospital is, then your physician would bill the ED visit, and then that hospitalist would bill the initial inpatient. And that's as long as those two practitioners are not the same physician within the same, not the same physician, same specialty within the same group. Next question.
Is there a listing that WPS follows that would all fall under parenteral controlled substances?
No, WPS does not have a specific list. There is information within the Drug Enforcement Agency, and I apologize, I don't have that website listing. We will provide that to you in a follow-up document that provides a list of what the DEA considers to be controlled substances. But again, we'll provide you that web link in a follow-up email. Next question.
All right, so this one regards the example with the moderate risk being assigned for the patient with bradycardia. And the question is, why was risk moderate based on this diagnosis and not on the treatment plan? The guidelines say, while condition risk and management risk may often correlate, the risk from the condition is distinct from the risk of the management.
Okay, I think that was example 3, but let me find that one. Okay, and the reason why we went the way that we did on this one is based on the documentation. This physician is not going to treat the bradycardia. This physician did not indicate that the patient's condition was a more urgent type of situation. So that's why we went the way we did with assigning this. Let me get back to my page. With assigning this as a moderate risk. Now, again, keep in mind what I said earlier, evaluation and management services are not an exact science. So if we coded it that way, a 99284, and your physician and your office believes it should be something higher, then you'll request an appeal and point out to us why you believe that risk to that patient is higher. And you want to think about what it is your practitioner is doing. In this situation, which was example 3, the practitioner is not ordering the monitor. They're not, there's no information in there about a referral to a cardiologist. What was the other thing that was in my head? Said the patient was asymptomatic, and they're not addressing that bradycardia other than they did order an EKG while the patient was getting the laceration. So because of that, that's why we went with the moderate risk for that patient. If the doctor had identified referral to cardiologist, ordering the monitor, doing any of those things, that could have indicated then that that practitioner believed that that was a higher risk for that particular patient. Next question.
All right, and this next question kind of goes along with what you, I think, just addressed, that it's not an exact science when assigning these categories. But the next question is regarding the example with the CT. So based on the amount of radiation in a CT, this would always carry a risk to the patient and should, in this person's question, should be considered at least low, if not moderate risk. Can you expand on why you feel there's no risk to the patient when radiology or specifically CT scans are performed?
Okay, sure I can. The practitioner who wrote the note did not indicate any risk. One of the things that you really want to move away from, and we understand that with the way services were coded prior to 2021 for office another outpatient, prior to 2023 for the other category of E&M services, it was more of a counting type of situation. You evaluated the documentation, you looked for review of systems, made sure all of history of present illness was there, how many different systems and areas were examined, etc. With the new documentation requirements, though, by the AMA, it all goes back to that documentation. So to say that a CT scan is always a moderate risk is an inappropriate statement. For one of your patients, it could be a high risk. For another patient, it could be a straightforward risk. It depends on that patient, what you're treating, what are those medical decisions that are being made. And your physicians and practitioners need to show that proof of thought as to the risk to that patient. Next question.
All right. Next question is, in reference to the wrist injury, I thought over-the-counter medication was considered low risk versus straightforward. And then kind of combining two, why wouldn't you count Tylenol or ibuprofen as low risk?
Okay, because again, there's nothing in here to show a risk to this patient. Everything goes back to that documentation. The patient has already been taking Tylenol. The physician did not indicate that taking ibuprofen would be a risk to that patient. And therefore, I have to go back and find that. I think we did that one. We did that risk as straightforward. Now, if your ibuprofen, if there was information within the medical record, and it is not in example number 1, but if your documentation shows that the physician was concerned about ibuprofen interfering with some other type of medication, then you could move this to a moderate risk. But based on the documentation we have here, it is simply a straightforward risk. Next question.
All right. So kind of to piggyback on this question for the bradycardia example, I think I just want to clarify their question wasn't about bradycardia being a risk on that. I think the question, it says the question, their understanding was that risk is calculated based on medication, procedures, and diagnostics, not a diagnosis. So can you just clarify a little bit on, I guess, picking criteria to pick risk off of?
Okay, when you're looking at risk, and really you want to have conversations with your practitioners about indicating this within their documentation. The AMA says that the risk to the patient is from the illness or the problems that they have and your medical decision making. So for an example, we had the patient who had fallen off of the ladder. Okay. So our problem, we may have considered that there could have been a head injury. Okay. By the time we get to determining what the plan is, though, we know that the patient doesn't have a head injury. So in that situation, what we look at for the risk to that patient is the laceration to the elbow, any medications, any other types of situations that we may have for that patient, and what is the risk to that patient from the decision that we made, which was to sew up that laceration and send them home. It is going to be difficult, okay, for your coders and your billers to evaluate that without assistance from your physician and practitioner community. It's not, you can't just say, okay, we ordered a medication, therefore it's always a moderate risk. That's an incorrect statement, and it is not valid based on how the AMA has presented this. Now, sometimes ordering a prescription medication or reviewing prescription medications, that could be moderate, but not always. It's going to go back to what is the risk identified to the patient from your practitioner based on the medical decisions that he or she is making. Hey, Rachel, we have time for one more.
All right. Let's see. We have a couple of questions, so I just want to make sure I get a good one. If a provider wants to admit the patient, but the patient refuses, and the documentation supports that, can you count the decision regarding hospitalization and count? I'm sorry, as I'm reading this, I might be a bit confused. I think the question is, can you count the patient refusing to be admitted as high risk in your documentation?
Okay, so what you want to look at in this situation, and this goes back to the example we had with the nosebleed. In the first ER visit, the doctor advised the patient to accept the observation care, and this really is kind of an escalation of care. I'm looking at my AMA document. So depending on the situation and how risky they believe that nosebleed was for that patient, the fact that they are attempting to escalate the care could be considered moderate risk, it could be considered high risk. And the fact that we can consider it that way is because that physician documented that. They included their proof of thought that maybe there's, we need to be watching this patient for a little while rather than just the patient going home. Now, in that first example, that first ER visit, the the patient, however, refused that, but you can still count it because that's still work that your physician or practitioner did. That's still their expertise, their knowledge coming in to take care of that patient. Now, um, and it has to be documented. In those two particular examples, both of those practitioners identified that that's what they wanted to have happen with the patient. And so therefore we could move a little bit with the risk. On behalf of Rachel and myself, we just want to thank you very much for your attendance today. So thank you very much for your time today, and you can now disconnect.